Okay, hello everybody, and welcome to this webinar session with me, Dr. Win Okuda. Today, the title is called Simplifying Complex Cosmetic and Restorative Dentistry. First of all, I want to thank Viva Learning and they're for hosting this wonderful webinar. And I know I have a lot of great colleagues who are on it, and wow, everyone's just jumping on it. So it's getting going to be a huge audience. And also wanted to thank Bisco for sponsoring. And, just so you know that although I use certain products like Bisco, that's not the only products I use. So I always like to share different types of things that I do so that you know that from a predictable and consistent point of view, that is what my main concern is when I'm doing dentistry, is being able to create the perfect results for patients that are long lasting. So, and one of the things that I've been doing over the last 34 years is really learning a lot about complex, seeing so many complex cases. I treat so many complex cases. I have done a lot of, just my own, continuing education and in implants. So I mistrained over 22 years ago, and I'm also an accredited fellow with the American Academy of Cosmetic Dentistry, and so that means basically that I do a lot of complex cosmetic dentistry. So I wanted to share with you how I'm able to simplify it through the course of my journey through cosmetic and restorative dentistry, and including also some surgical tips so that you're able to do this, from next week, from Monday morning. Okay, so let's get into this here. And so let's go back here. Sorry. And, so I'm here from Hawaii, Honolulu, Hawaii. I'm looking out into the ocean right now. And so wherever you're at, I think we can hopefully be able to enjoy a little bit better weather. Now it's the fall, so I love this time of year the best. Yes, I'm past president, 2000 to 2003. With the American Academy of Cosmetic Dentistry. I'm also one of the accredited fellows. So there's, I think, maybe 89 of us in the course of 35 years or so. And, and you can check out my website if you want to see the type of works that I do at okudacosmeticdentistry.com. I love showcasing cosmetic and restorative dentistry because I think I'm an artist at hand, and then secondarily, being able to then create the technical parts of clinical dentistry to meet the artistic means in which how I do dentistry. And so when you have complex cases like this, it really is, there's different ways of approaching this. And one way is, when you have a case where you have an implant that's errantly placed, you can see that in the lateral incisor, and this person is just hates her smile. How do you then correct something like this? Now you can do an open flap type situation and change the dental gingival complex, or you can do things more simply. And so that's what I'm going to showcase with you, that although I do see a lot of cases, in literature that people are doing open flaps when they're solving cases like this, you don't have to do open flaps. Okay. And so that's why I want to share with you how I'm able to then, correct complex cases like this and be able to create a beautiful smile and one that looks natural. And again, 34 years of experience solving these cases. These are things that I really hope that we'll be able to then help you with problems that you may see. Again, I want to thank Bisco for sponsoring this lecture. I am receiving an honorarium for this. But, the most important thing, like I said, I wanted to let you know that I've been using Bisco products since 1992. So when they first came out with All Bond 2, I've been using that from 1992. And since then, I just love the chemistry of Bisco. Like I use a lot of different products from other companies as well. But when it comes to great adhesives and a great family of products, Bisco is something that's my go-to material for heavy restorative. Okay. This here is a picture of me and my former practice manager of 21 years in the past, Julie Pusateri. We did this at ADA in Las Vegas. So they selected 5 of us to do live dentistry. And so I'm very proud of just my journey of how I've been kind of doing things along the way. And so I wanted to just share with you some of things that I've been doing so that you can learn and you can be able to apply in your clinical dentistry. I always talk about quality. Quality is the most important thing that you want to try to achieve. You know, when you look at a case like this where there's veneers, and then I've done some gingival changes, a case like this, you need to be able to focus in on quality, because to me, really, to deliver a quality product, you need to have two parts of this equation: is predictability and consistency. I always like starting off my programs with this, because this is what gives us long-term success. And that's what we always want to be striving for, folks, because in the end of the day, the only thing as a dentist we have is our reputation. And so with our reputation, it can either be good or bad. And I'll tell you, with the whole social media, you know, Wild West out there, you should be concerned about your reputation, because people can write some bad things. So really, if you focus in on quality and you focus in on predictable and consistent types of procedures as well as products, you won't go wrong. Okay. So here's just a little bit, for those who don't know me, a little of my background here. Past national president, and as I mentioned, board accredited fellow. Very proud of that. I achieved that in 2014. So, you know, to me, it's just, I feel like I'm, you know, always excited about doing dentistry. I've been on the expert advisory board of the AGD, as well as one of the things that I'm really quite proud of is the fact that we created Give Back a Smile National Charitable Foundation, which is over 20 years old. And the other thing that I'm so passionately involved with is the Pan Pacific Dental Academy. So if you want to learn things, not just about clinical dentistry, but about powerful practice management and just great business development ideas, go to panpacdental.com. So, you know, we don't just teach clinical dentistry, we teach powerful practice management and business. And so that the three that I see, that's super important in being able to create the best practice that you can, you know. So go there. A lot of videos are free, and there's a lot of different things you can check out there. Okay, so feel free to go to that. Now, I want to start off with this statement that patients can feel excellence. This is related to quality, because, you know, you think that just because it's in their mouth that they can't see what's going on. Believe me, people can tell when something's not good, and it's because they can not only, if they don't see it, they can feel it, that something's not quite right. So we need to be really concerned. Now, I use this term Okuda axioms, and Okuda axioms are basically, it's truths, things that we rely upon, patients rely upon. So, you know, again, quality dentistry is what you want to try to get to. Okay, so there's a before and after of a case like this, and obviously this is an occlusal type situation. This is why I will do indirect restorations. Like, you know, I would be careful. I see so many people doing direct restorations in cases like this. You know, I will tell you, and I've been doing direct restorations since 1995. All right, or earlier than that, but 1994 or so. And so I have tremendous experience. I will tell you, if it's an occlusal based problem, you know, type case, don't do direct, or else you're going to be redoing that case, and then you're going to be eating the profits of more case, you know, of your next two cases, just because you did it wrong. Okay, so you got to choose smart, you got to choose wisely, and you know, and be aware that there's limitations to direct resin. So what does successful dentists do? It's really about recreating nature on a foundation of functional occlusion and good gingival health and dentition. This is what I do every day for my patients. Okay, I integrate comprehensive dentistry. That is what I've been doing all this time, and I've been very fortunate. I feel very fortunate. I've developed a very successful couple of practices with this. And that's why I share this with through the Pan Pacific Dental Academy. So you can catch me and Julie, my former practice manager, because she knows so much about practice management of not just of a cosmetic practice, but of different types of things like DSOs and single practices, pedodontic practices, all kinds of things, periodontic practices. So she knows a lot about practice management in different forms. And if you go to, if you do this, you will attain long-term success. Okay. So go to panpacdental.com. We have we do have PACE approval. So that means that when you do these modules, you're given legit continuing education hours. So this is a case that I will showcase later on, but here's the before and after, and you can see how I really am taking care of not just the beauty of it, but of the gingival health and of the occlusion as well. Because to me, it's this is the epitome of that balanced triangle. Creativity is a foundation in which I do everything, because creativity allows me to be able to then find solutions to things that are very complex. All right, so this is a foundation in which how I do things, and I've exercised that creative side of my brain. So I definitely would encourage you to really kind of look at solutions in a different way. Don't look at it from a traditional point of view. And if you don't know quite what I'm talking about, then go to the panpackdental.com and you can understand how I think, so that it'll help you to creatively be able to then find these solutions on these comprehensive cases. You won't regret it, I will tell you, because I've been doing this such a long time. And to me, it just really is the key to success. And so when you're really thinking outside the box here, okay, then you're going to find that it's a game changer, the word creativity. So you really want to be exercising that. So let's start off with this here, simplifying a broken tooth at the gum line. Now, this is a case that you will see in every practice, okay? You're going to have patients come in with this. And really the question is, what do you do with a case like this? Can you solve a case like this? Can you salvage a tooth like this? Well, what if a patient is in their 70s and they can't afford an implant? Can you, in fact, help this person by salvaging a case? Certainly, you could take the tooth out and put an implant in there. But what if they don't even have time for an implant and they want to have a tooth immediately? Can you solve this problem? Well, with accelerated combination treatment, you can solve this problem. Now, just so you know that this is something I kind of coined, accelerated combination treatment. And really what it's about being able to multitask so that you're able to solve problems in faster timeframes. So folks, remember this, that because of the internet and because of social media, people have had instant gratification of things, right? That they're able to get things instantly. They expect dentistry to do the same. What have we always done is traditional models, and see a patient every other week, treat this tooth, treat that tooth. But you know what? Patients no longer want that. And they expect dentistry to change and no longer be the dinosaur in terms of how we approach treatment. We need to modify in the ways in which we do things creatively in order to then problem solve, so that we're able to then correct problems in short time frames and in less number of appointments. So some people may say this is not salvageable, but let's see what's possible here. So this is what it looks like. And you can see here how the tooth is broken off at the gum line. But is it, this tooth, there's no mobility. Can we give it some life? Okay. Can we, in fact, be able to then treat this? Because there's so many patients. It's not just about the cost of money for treatment, but the loss in time in undergoing treatment. On a case like this, think traditionally how it would need to be done. You need to do a root canal because it's broken into the pulpal chamber. You need to do perio surgery. You need to do post and crown buildup. How many different appointments would it take for you to give a tooth back to that patient, a final restoration? For me, in my practice, it takes 2 treatment appointments, okay? I can give them a temporary, and then the next appointment, I'm giving them a final. So does that seem really almost, wow, like just a little bit like how do you do something like that, right? Well, let's talk about how we do that, okay? So when you have a tooth that needs a root canal treatment, as long as it's not effective, you can do a same day endo, start to finish. And then I create a post space immediately, same day, okay? And then I'm gonna use a dental adhesive and a total bond, total etch technique that allows you to have maximum megapascal strength. So I use all bond universal in a case like this. If you have if you have enamel, you definitely want to use a selective etch technique. However, in a case like this, you can, because it's purely dentin, you can use this technique here. And then I'm going to use a post. So this post, I'm placing it in with a self-curing lutein resin. Now, the thing is this, I like using the same family of products. Why? It's because when you're using the same family of products, then you know the chemistry is going to work together. Now, although they say that, yeah, you can use this with other manufacturer products, and so you can mix and match, I don't really like to do that, because when a manufacturer creates a product, it's with the make sure that the chemistries all work together. So that's why I like using, in this case here, when I need maximum strength, I'm going to use everything from the same line, what I call family line of products. And then from there, I'm going to use a buildup material. Now, this is a buildup material that is called TheraBase. TheraBase is a wonderful material because it's a self-adhesive resin buildup. What it does is also, because it's self-adhesive, it has an etching component to it, and then it goes back down. So it goes back down to neutral pH. So it's wonderful, and that is also radiopaque, and it also has a really high stress, so shear stress type of product. Now, you can't just go ahead and restore the tooth like this. And I've seen cases where people will restore it just like this. Now, if you restore it after you build the crown buildup and you don't address the ferrule, then you're at the mercy at the material itself. But if you go ahead and you move this tissue down to gain more ferrule, which is the base of the actual tooth, now you're at the mercy of the tooth. Okay, if you now let me rephrase that, is that you want to be sure that you are gaining tooth structure to hold on to with the new crown, and not just putting it on this material, or else that material will fail. It will break off within a year. Okay, there's no material that's strong enough unless you go ahead and regain ferrule. So let me show you. This is regaining ferrule. All right, this here area in which we are able to recapture is the ferrule, and you want to have about 3 millimeters of this. And so how I am able to get that is I use a closed flap peri-surgical procedure to reestablish the ferrule and the biologic width. So I use an I+ water lace from BioLace to accomplish this. And so let's talk about this concept a little as to how you're able to do a closed flap, because this is how you're able to simplify periodontal surgical procedures. Okay, I have been doing this since 1994. So let me share with you. This is the actual article in which I based a lot of this on originally. So this is done by John Coyce, Altering Gingival Levels. And it's regarding then, in this particular article, is regarding the biologic width variables. And so in 1994, I read this and I thought, wow, this is a real game changer here. So all what John was saying was, in a normal healthy tissue, the position of the osseous crest in the anterior is 3 millimeters from the facial free gingival margin and 4 millimeters from the interproximal facial gingival margin. That is an important, this number 3 millimeters is very important, because this 3 millimeters then allows you to know that the new biologic width, you won't have biologic width infringement as long as you have 3 millimeters from the osseous crest to the free gingival margin. So you need to know where the base of the sulcus is, because that defines the cervical limitation of tooth preparation. Then you need to know where the osseous crest is, because this determines where you're going to be able to establish that 3 millimeters. So when you have 3 millimeters, you know that it's going to heal to that point, and you're able to then predictably alter gingival levels. So I'm going to show you in this and its more complex situation, so you fully understand this concept. This is super important, people, so that you're able to then really simplify these problems. And you can do this in anterior areas, posterior areas, so many different areas, okay? But you need to understand, first of all, crestal position. So biotype is really important. There's normal crestal, there's high crestal, and low crestal. And in reestablishing dental gingival complex, or the biologic width, the periodontal biotype must first be identified. Once this is determined, the necessary minimal invasive periodontal surgical procedures can be treatment planned, such as a gingivectomy or closed flap. Okay, so let's say, for instance, you needed to regain this ferrule here. If you had a low crestal, you can just simply do a gingivectomy, knowing that the crestal bone is already low, and you're able to then reestablish this and have 3 millimeters from where the new margin would be to the actual bone. Okay. However, if you had a high crestal situation and you needed to then do the exact same thing, which is to gain more tooth structure here, then you can see how the osseous crest is in the way. And so if you were to go ahead and try to do a gingivectomy here, you're going to have exposed alveolar crest. That you would need to move 3 millimeters under the new gingival margin. That's what, so let's look at how we're able to do that, okay? That critical piece of information allows us to understand how we're able to predictably reestablish that dental gingival complex. The position of bone enables the clinician to predict the final outcome of the tissue aesthetically, that because you know exactly it's 3 millimeters, okay? And this is not just written up by John, but many different practitioners talked about this, back in the 90s, the late 90s. Very important information, and you don't want to dismiss this, because remember, the works of what we have done historically through evidence-based is really the foundation how we're able to move forward. So let's look to see in this particular case how I'm going to reestablish the dental gingival complex. First of all, what I need to do is to know, okay, I got to move this margin down so I have 3 millimeters. Okay, 3 millimeters, this is the ferrule. We're going to have new ferrule here. But then if I needed 3 millimeters from the new margin to the actual new crestal bone, that would take it right there on the actual bone itself. And so that's not good, because then that's why I would need to move this crestal bone down here and this crestal bone down here in order to have room for where where you're going to have reestablishment of the dental gingival complex, which is 3 millimeters. Okay, so keep that. This is what we need to be looking at. So let's go ahead and continue on with this case. So you can see here how I'm using the I+ in, first of all, doing gingivectomy, and then I'm going to be doing a closed flap. This is a wonderful device because why? Because it makes it so simple. In comparison to an electrosurge, you're not burning tissue. You're just vaporizing and removing tissue. So there is no charring involved. All right. So I would not be using an electrosurge at this point. This is a way of being able to reestablish biologic width in the most conservative and minimal invasive way. The nice thing about the I+ is that it's already dialed in. You don't have to know about wattage or power or anything like that. There's all of these icons here. And, like say if you're doing a gingivectomy, it'll show you like a rapid mode, a smooth mode, and then tissue-plasty. And then, so you just go down the list there. Or if you're doing a closed flap, you're going to have a gingivectomy, and then you have an ostectomy, which is removal of bone for the closed flap, and then a bone plasty and a tissue plasty. So you're just going down. If you're going to be doing like a implant repair, it has a list for its that. Or if you're doing like periodontal repair, it has its own menu for that. So it's really quite simple. But it's important to understand that this type of technology to me is really important as we go forward with dentistry. So from there, you can see how I not only did the gingivectomy, but I also did the closed flap, so that I reestablished the 3 millimeters from this margin down to the crestal bone along the whole perimeter of this tooth. So, and then I regained ferrule here. So then from this point, folks, I know how this is going to heal. It's going to heal exactly in this position. Okay. Now you would say that, well, then I'm going to have to wait and then we'll take a final impression. And for me, no, I'm going to take the final impression today. Because if I know where it's predictably going to heal, then why not take that final impression? And I know that's a leap of faith, folks. But the most important thing to understand is that that's science, that's biology. And that's where this evidence base becomes super important. So let's say after I refine the prep, reestablish biologic width here, same day final impression. This is 1 month later after I saw that patient come back. I knew exactly where the margins were going to heal. Okay. And then from that point, you don't have to worry if the margin is too high. All you have to know is that it's 3 millimeters, from to the crestal bone. Then I'm able to then look at this. This here, I knew exactly where this was going to heal, this margin. And then from that point, we're going to go ahead and we're seeding the final restoration because I already took the final impression on the same date that I did the root canal, the post-crown buildup, and the closed flap. This is where now the progressive materials become important because you need to have something that is going to be strong for this. And this is where you want to be. You don't want to be using second, third tier type products. You want to be using products that have great chemistry and is predictable in its outcome. So when I get the crown back, it's important to then immediately put Z prime on. What is Z prime? Z prime is a primer for zirconia. So if you were to then, because I know that some people talk about using hydrofluoric acid for etching and silane coupling agents, that is not used for zirconia because zirconia does not have silica. It's different. The polycrystalline structure is silica free. So that is why you cannot bond, like say a silane coupling agent to zirconia. You need something specific for zirconia. And that's what this product here contains. MDP, which is a tremendously researched adhesive. You increase the bond strength to zirconia. And I've seen this, okay, because I've had to take off my crowns that had been bonded this way. And I will tell you, it is bonded. It is bonded. So I can tell you firsthand, this works tremendously well. It's compatible with light cured and dual cured resins, and it enhances the bond strength. And all you got to do is two coats from this one bottle. Okay. The key is this: you want to put the Z Prime Plus in the crown prior to trying it into the mouth. So why is that important? Because you want to reduce any sort of problems with salivary contamination. If you don't put the Z Prime on inside the crown and you put it in the mouth, if you get saliva in there, you're not going to get bonding. Okay, no matter how much you rinse it out, you're not going to get bonding. I'll show you a remedy for something like that. But I always tell my assistants, be sure you put that Z Prime Plus in, because then once I put it in the mouth, if there's saliva or blood that gets on it, I can rinse it out because the material is hydrophobic. But at least it's coating onto the actual zirconia. Then you don't have to worry. So what we do is we micro etch the intaglio surface. Here, we micro etch this, then we put 2 coats of it on here. We let it sit for 5 minutes. This is the crown that I'm going to be using for that lateral incisor. Then I'm going to clean the preparation, the tooth preparation, with a pumice slurry. I'm going to disinfect with a cavity cleanser and Microprime G. I like using Microprime G, especially for vital teeth, but I use it for everything because of the glutaraldehyde. And so it helps. It's a tremendous desensitizer. Okay. So look at this is here. The same day we're putting that in, look at where that margin is. It's exactly where I knew it was going to be on both sides of the prep. All right. Now I know that's why I could take my final impression. Now, if you're not confident, and this is the first time you're going to be doing this type of procedure, then take a final impression on another day. All right. Have that middle day where you bring a patient back, take a temporary off, and then you take your final impression after it's healed. Give it about at least 3 weeks for it to heal. But it heals when you're doing with laser, I tell you, it heals. It's amazing. After 1 week, it's almost healed. 2 weeks, it's fully healed. All right. In comparison, when you're doing a traditional surgical reflect and full reflection, then I will tell you that heals like 3 to 6 months. All right. And it's pretty darn painful. So that's why I prefer doing closed flaps for my patients, because they don't feel any of this. And you don't have to send it to a periodontist. You can just do this, and of course, that's great for practice management as well. So now here comes Theracem. Theracem is, after I put the Z Prime, Theracem I place in the crown, and I hold it with pressure so that I'm able to be sure I get it really marginated correctly. So I put pressure on it, and then I release the pressure, and then I tack cure. All right. The amazing thing is this thing peels off so easily. This is the best cement I've ever encountered, the easiest I've ever encountered in all my years, because it peels off like putty. It just peels right off. Like it's simply that easy. And then after that, I cure. I'm sorry that after I tack cure, I peel it off, and then I floss the contacts, and then I fully cure, and that's it. And it's that simple. All right. In this case, why did I, so I use a zirconia core. So some people say, why didn't you use an Emax? And because to me, I really feel I need maximum strength. And that's where having the zirconia core is important. But I needed to then match it to these other adjacent restorations are actually it's actually Empress, the original Empress material. Okay, which is the Empress material is the original material of Emax, but this was in the mid 90s. So that's why this patient came to see me and then had the tooth broken off, and I had to try to match it. And my ceramist was awesome. They're able to match this zirconia with the overlay to this actual Empress, which is like a precursor of the Emax. Great job from my ceramist. Theracem was created as part of the family of products. Here's my great friend, Byung-Sa. Dr. Byung-Sa, I would tell you, if it wasn't for him, I wouldn't be the kind of dentist I am now. The chemistry, he's such a master in chemistry and he dedicated his life towards being able to create products for the dental profession. And I will tell you, if it wasn't for him, we wouldn't have these wonderful products. And he created this whole family of the TheraBase, the TheraCal LC, which is a wonderful pulp cap for vital tooth type of indirect and direct pulp capping, and then now this Theracem. So Theracem, which is a material I use to seat this on, is self-adhesive. It contains MDP, so it bonds to the actual Z prime. And then it has a high shear bond strength. And because it's a self-adhesive resin, it starts off as being acidic, and then it goes back to being neutral pH. So it's a rapidly increases from an acidic to a neutral pH. And I think one of the great things is that it releases fluoride and calcium. So it's an anti-caries type of cement. It does everything that I needed to do. 2 appointments, broken off at the gum line. And then after the root canal and all the things we talked about, here's you can see how we're able to then control the outcome, have a wonderful result just like this. And you can see how I moved the dental gingival complex up, and then now I have good biologic width, so I don't have any infringement upon biologic width, but yet I have the ferrule under the crown. Okay. So as we look here at the issue about silane primer to zirconia, I want you to see how low megapascal strength this is. That's why you don't want to be using a silane coupling agent to prime zirconia, because it has no silica. It needs to have something that is for zirconia, because it's a different polycrystalline structure, as I mentioned. So what if you forget to Z prime, before you try it, and now you got saliva contamination, right? So if it's contaminated, then here comes the next protocol. You use Zirclean. Zirclean is a wonderful product that helps to clean off the surface, the intaglial surface, from salivary proteins. And so this is my protocol. I use that for 5 minutes to remove the salivary protein. Then I rinse dry with oil-free air. I suggest that you all get an Adic tooth dryer. If you want to have great bond strength, you want to have it's oil-free and water-free. And then I micro etch the intaglial surface, and then I'm going to Z prime plus for 5 minutes. So it's an additional 5 minutes to actually clean off the surface. But rarely does that happen. My dental assistants, they're on it, so they put the Z prime on, and even though I ask them all the time, I know it's on there, but because they're always on it. So, but just in case, if you have that other protocol, just in case you forget. So one of the things about, I think it's really another complex type situation is short preps. Okay, I think people run into these problems, especially along, second molars. So I wanted to talk about this really simply. And then, I still use zirconia restorations, but the one thing that I change is that I don't use then Theracent. Instead, I'm going to use a combination of All Bond Universal and Dual Link. So what I'm doing is I'm using my heavy, heavy, heavy stuff, which is the All Bond Universal. I'm going to do a total bond, total etch. And then Dual Link is the dual cure resin cement that I'm going to be using. That is going to give you maximum adhesion of a short zirconia crown. Now, remember that because it's a family of products, that Z prime will bond to that all bond as well as to the Dual Link. So you don't have to worry about it. But it also, you got to look to see your prep design as well. So here's a prep design on a short second molar. I use retention grooves as well. And then I will micro etch, place C prime plus inside. And then now I've reduced the issues of problems with my zirconia crown. I'm going to clean the prep, pumice disinfect. I'm going to put All Bond Universal on the tooth and light cure. Then I'm going to place Dual Link, which is a dual cure resin bonding. So you can use this for Emax. You can use this combination here for Emax as well. It's a perfect combination for Emax, by the way. And then you tack cure, and then I'm going to remove the excess, floss the contact, clean up the margins, and then I light cure fully around it, and you're done. You just got to do some cleanup. That's it. Bonding to zirconia. Look at this. When you have zirconia, you use Z primer here. Okay, Z, whether it's polished or sandblasted, look at the megapascal strength you get when you have Dual Link. Amazing. To me, it's just simply amazing. All right. Well, let's go on to the next case study. This is actually the case study that is really a nice cosmetic case. And I showed it to you earlier as one of the first cases, but I wanted to show you how I simplify a complex type smile design case. So, as I mentioned, I've been doing this for 34 years, and I've seen so many different complex things. But one of the things is that I've been very observant. I've been lecturing around the world for nearly 30 years. And so I have a lot of great colleagues around the nation, around the world. And I'm so blessed that I've been able to do this and have created so many wonderful friendships. So to all my colleagues out there, thank you very much for your friendship, throughout the years, and your kindness. But, one of the things that I did do is when I go to those different countries, I learn from what they do. And that's how I'm able to simplify the types, use that as part of my creative, and I put that into my creative mind. And then I create different protocols, and I create different ways of approaching dentistry, which is some of the things that you're seeing right now. So, it's just that we insist on making things complicated, especially as we're younger. But as you become older, you realize that, you can simplify this stuff. And so that's exactly kind of this article that I created back in, I think this is 2018 or 2019, but it's the innovative approach to complex cosmetic dentistry. And so let me share with you this case. This is a Sky. She's a 26-year-old female, congenital problems with anterior teeth. She had seen 5 different orthodontists, and they all said they can't help her because she has microdonts, misshapen teeth, small and disproportionate anterior teeth. And the best thing that's going to help her is cosmetic dentistry. And so she wants a beautiful smile, obviously, because she was born with this. And you can see how she has that gumminess too, that doesn't help. That, it really kind of creates a childlike appearance to her. She's 26-year-old, but she looks like she could be like 16 years old, right? So how do you then create a much more mature look is with really combining cosmetic dental protocols and surgical. So you can see when you look at both sides, look, you can see the heavy gumminess along here. And in particular, you can see when she smiles, she has beautiful lip line, but you can see how small this one tooth is. Some of these teeth is going to be changed with gingivectomy, others with closed flap. And so I want to share this with you because this you can do instantly, especially if you have a BioLace I+. But if not, I would highly suggest you will get one, because that to me is like an amazing tool that everyone should have. And this, I've been doing this for a long time, but to me, it's like I'm reborn because of laser dentistry. So here we're going to go ahead and I'm going to mark where I'm going to move my tissue. I have seen even recently how people approach this, and they'll do like full reflection flaps. And to me, you're complicating things way too much. Okay, you can do this so much simpler, so much more painlessly for patients by doing this technique that I'm doing. All right. And also because when you do full thickness flap, you are now changing the way things heal, and it can really kind of mess up a cosmetic case. So keep it simple. That's what I like to share. So this is where the new free gingival margin is going to be. And remember what we talked about. Then we want a perioprobe because we want to find out where the crestal bone is, because we need to be sure we have that 3 millimeters. And so verifying, and I see people using jigs, using digital dentistry jigs and whatnot. You don't need to do that. You just use the human face, okay? And then you're marking it, and I'm looking and double checking before we actually anesthetize a patient. Then from this point, I'm going to perioprobe, along here, because I want to verify. And this here in particular is a high crestal, and you'll see in a moment. Okay. Then we go back to this, what we talked about, this topic, so I just wanted to remind us about the 3 millimeter rule. And we need to know where the base of the sulcus is and where the osseous crest is. Okay. So we want to get to 3 millimeters. So right now, as I perioprobe, this here is at 1 millimeter. You can see the crestal bone is right here. But if I'm going to remove this in a gingivectomy, I'm going to expose alveolar crest here. Now, you have to remember that, one of the things that's important here is that you got to have the right amount of crown to root ratio. If you got short roots, this is not a good procedure for this. So, but the thing is that if you have good long roots, or at least average size roots, because this is a canine, you can move this crestal bone up here. All right. Look, I'm going to, and then I'll show you. So this is 1 millimeter. I need to move the gingivectomy here. You're going to expose this alveolar crest. You need to move that alveolar crest up 3 millimeters up to this way. And that's how you're going to get this. And you have to, and like I said, as long as you have good crown to root ratio, you're fine. These other teeth, I was able to do gingivectomies, and I think I did another crown lengthening on another side, on the opposite side, doing a closed flap. Okay. As I mentioned, look, you can dial this in really simply here with all these different procedures. This is what it looks like right after I do my laser. My laser treatment. It doesn't look good, but then right after this, I'm going to prep, because like I said, I combine prepping and surgical same day. Because why? Because I know exactly where it's going to heal before it heals. So this is so using the modern approach to biologic width, as I mentioned, are articles that really substantiate why I can do what I can do here in getting the results. Then it's important now we use temporary prototype. Prototypes are important because it's really about realizing the vision of your patient. And the only way you can realize a vision is for them to be able to test drive the new smile. And so I wrote an article on this many years ago in Oral Health magazine from Canada and I called it back then aesthetic transitionals. This is back in 2001. And to me, and now it's slightly different how I approach it, but still the concepts are the same. But the most important thing is why it's so important to be able to carve out aesthetic. I call them now aesthetic temporary prototypes. All right. So the key to success is you got to have a wax up. Okay. The wax up is based upon their face. And then from there, with this particular case, here's the prototypes after I did the preps. You can see here, I like to show this because you can see how uniform the preparation is. All the thicknesses are the same, in terms of facial, from the facial contour to the intaglio surface. They're all prepped evenly. So that's really important because you want to be sure you have proper, you're controlling internal color as well. This is what it looks like 1 week later post-op. Can you believe that? 1 week post-op, it looks just like this. And you can see where the margins are. It's exactly where I left them. to this case. Now you could do a no prep on a case like this, just or maybe a mini prep. So have at it, however you choose to want to do it. I just like putting margins because that's how I am, because I like having margins on there. And if you don't and you think you can do it with no prep, fine. That's use your protocols in there. But the key is really make the aesthetic prototypes so that your patients are able to then assess this. Okay, so this was after the closed flap procedure using the erbium chromium YAG. Here's the aesthetic prototypes to the patient. This is 1 week later, she came back. Look at this. Look at the tissue, how it's healed. I think it's amazing after 1 week. And this is what she looks like. Now she's able to tell me what she likes and don't like about her smile. Because why? Because she's test drived it. And what I like to do is I like to work with my patient in co-designing their smile so that we're able to create individualized smile design. Now, this is what I consider part of what I call modern smile design 3.0. Now, there's also smile design 1.0, which is the most, the most traditional way of smile designing, and then what I call 2.0. And now I'm at 3.0. Now, if you don't know what I'm talking about, then go to panpacdental.com, and there's actually, you'll see there's actually different, there's two different webinar lectures on that, and I believe it's free. So so just go to that website, and you'll be able to then find out what I'm talking about more. And here she is, and it's just really simple. There's no sound on this, but the most important thing is I'm able to then, this is what the aesthetic temporary prototypes, and I asked her a question: what do you think, Sky? What do you think? And see what she has to say. Oh, you see, you don't need any sound. Look at her face, how it's lit up. Look at the proportionality. Look at how it balances to her eyes and her facial shape. This is what we want to have before we go to the permanence, okay? And then from there, what we're going to do is then we deliver to the ceramist, along with many different other types of records that I do. And again, this is something you can look at. You can look at additional webinars that I've done on the panpacdental.com, and it'll specifically go through all the different types of records that I communicate with my lab tech. Okay, and then they produce the ceramics. From there, devil's in the details. Let's talk about it. First, the try-in. I want to be sure that everything looks good. She's got the thumbs up going on there. And then because we want to be sure we create ownership with the patient. Then the patient needs to sign off on the case. I always advocate that because they need to create ownership into the case. And now this is with feldspathic porcelain. We're going to go ahead and we're going to treat this. I use phosphoric acid for ceramic now. Remember, we talked about zirconia earlier. Now with ceramic, you can see how the etching pattern develops here with phosphoric acid. And then, and so when you're looking at phosphoric acid, 9.5%, I'm sorry, hydrofluoric acid, not phosphor. So it's hydrofluoric acid. And then it's for feldspathic, it's 90 seconds, 30 seconds on lithium disilicate like Emax, okay? And I like to use then a two bottle type of bisilane. This is so that I have fresh chemistry, but look at the megapascal strength. With the silane, it's 42 megapascal strength. Amazing. I'm going to use that. All right. And like I have veneers in people's mouth for over 20 years. So this is, 20, 25 years and ongoing. So it's because of this chemistry here. So, and then after I place my 2-component silane, I'll place my porcelain bonding resin really thin, and then we're ready to go. Okay. So here is the, you can either, now I know Bisco has this, it's either a prehydrolyzed 1 bottle or the fresh chemistry 2 bottle. I use the fresh chemistry 2 bottle. Okay. And then I use this porcelain bonding resin very thin right here as the last, after we have the bisilane on. Then I go through my state-of-the-art bonding technique. I will isolate with an Optrogate and a 4/0 suture cord. Okay. The 4/0 suture cord is placed inside the sulcus so that I'm able to soak up gingival trabecular fluid and be able to lift that tissue slightly to expose the margin. But the more important reason, you can see here how I'm able to control, all of these factors. You see right here, a little bit of bleeding, but no problem. I'm going to be able to with my tissue isolation techniques, and then also how I manage this. I'm able to then not have this become a problem. You can also use a laser and do like a tissue plasty right here to cauterize that. Okay. Then I'm gonna, after I place pumice, then I cavity cleanse, with chlorhexidine. Then I'm gonna use a selective etch technique. So this selective etch technique I like using the HV etch with BAC. BAC is benzalkonium chloride, so it has antibacterial properties. This is really interesting because sometimes people will say, well, what if I don't use an etch? Well, you see, this is what uncut enamel and cut enamel looks like, but when you use phosphoric acid, then look at this, how this looks. This is what I want to bond to, okay? Because the durability of the enamel etch is dependent upon the etch pattern. So I like to do selective etch technique. Then after I etch, then I put my All-Bond Universal 1 to 2 coats, air thin it, and then we're going to light cure on all sides. And then we're filling with choice 2. I like using this luting resin. I've been using this luting resin forever, okay? And 95% of my cases is with translucent because all the color is built in. Sometimes I'll use something that's a little bit more where, either B1 if I want to increase the brightness. But then other than that, 95% is all with translucent. This is a light cured only, and that's what you want to have, a light cured only. Then I do a rapid seed technique. I don't like doing 2 teeth at a time. I did that a long time ago, and I could see the pitfalls because if something's just slightly off, the next set of veneers are going to be more slightly off. And then the next one that you do in the canines, it's going to be even more off. And you're going to be finding yourself adjusting interproximal contacts. What I find is this rapid seed technique allows me to get all the restorations in. I confirm the placement. Then I wipe off the gross excess with a brush. I leave a little bit of a film on the surface here by the margin. So I don't want to pull this off of here because if I pull this off, I may leave a void. So I'm going to leave a thin film there. I'm going to tack cure for 1 to 2 seconds, and then I'm going to start to do, then I'm going to start to break contact. I break contact with floss or horico saw to break the contact. Then I'm going to cure all surfaces for 15 to 20 seconds. And then I'm going to put a glycerin seal to remove the oxygen inhibited layer and light cure it one more time around the margins. And then I do a minimal type of, I like to keep very minimal to how I do my margin finishing. So I like to use a number 12 blade, and then I'll go with carbides along the facial margins because I don't want to start ditching the porcelain. So I use carbides. A lot of people talk about using finishing diamonds. I don't like using finishing diamonds on my margins. I like using carbides. Now, after you go ahead and clear it off, be sure you remove the suture cord. That's really important. You got to remove the suture cord, okay? And this is what it looks like after. And this is what it looks like post-op. You can see how I changed the gummy smile profile through my closed flap techniques, same day preps, as well as same day final impressions, predictable results, margin accuracy because of what we talked about. I'm able to do both surgical as well as the veneer preps the same day. And remember, you want to be always finding balance in all three. Okay, not just looking at beauty dentistry. You want to find balance for long-term success. Okay, so this is what it looks like post-op. Now, success is never measured by retracted views. I always, when it comes to cosmetic dentistry, it's what it looks like in the smile and how it enhances the face. You can see how I moved all this tissue up here, and it's very healthy on both sides. And here's the frontal view here. And look at how it impacts her face. That looks like what it should do. This is what I live for. And you can see here in this real simple video how she's just so happy. And so this article, you could probably find at Dentistry Today. It's probably that 2018 or 2019. This is what I want you to understand about, Steve Jobs said this: focus and simplicity. Simple can be harder than complex. You have to work hard to get your thinking clean to make it simple. but it's worth it in the end, because once you get there, you can move mountains. See, this is what I'm talking about. He's lived through so much of his life looking at complexity, and then he's figured out how to make it simple. That's exactly what I'm trying to talk about. Okay. And then to get the long-term successes, this is what we want to do. We want to use proven materials and sound chemistry. Don't mix and match materials. You want to be monitor and maintain stable occlusion, and you want to have predictable clinical techniques that work. And so hopefully what I shared with you in this simple hour will help you to be able to work with your patients. Remember, include your patients in clinical decisions, and devil's in the detail. But what's most important is that experience counts. So you know what? I know that, a lot of you younger dentists like learning from each other, but really, you should really try to learn from guys like us who are baby boomers, because we have lived a lifetime of a career in dentistry, and we can show you how to avoid a lot of problems. Okay. And that's what I try to do with my associates and the guys who are in my study club, Pan Pacific Study Club. So it's been really an honor to be able to deliver this to you today. I was so excited to share this with you. And so let's do some Q&A, okay? We got a few minutes for Q&A. We got 5 minutes, so let's take a look what we got here. Okay, I have a question. How do you determine one's perio biotype? What it is basically one of two things. It's either going to be, and this is what John Coyce, Frank Spear talks about. The biotype is really about, how you look at thick versus thin biotype. When it's thick biotype, then generally what you're able to have is something that you have a lot more room to make mistakes. So that's what's good. It's the thin biotype that you got to be really careful about. So when you look at someone's mouth, you look at their gingival tissue, and especially if you can see the bone underneath there, because the tissue is so translucent, that's thin biotype. That kind of biotype, you need to be very, very careful, because a lot of times with thin biotype, you'll have very little and sometimes dehisced types of roots up there. So when you take a CBCT, you'll be able to determine what the profile of the bone profile is, and then you're able to then determine if you got thick tissue up there, like thick cortical bone over roots, or is it really thin? And that's how you do. So it's visual as well as with CBCTs. So let's see. For complicated anterior aesthetic cases, do you recommend to splint the crowns or use single crowns? Okay, so this is what I do with temporaries. I always splint with temporaries because several reasons. When you put temporaries on, you want to be sure that you're minimizing the chance of it coming off. But it also does another thing, is that it doesn't allow the teeth to move. All right, because teeth can move if you use, if you're putting on temporaries that are single. And so then after that, all of it is all individual. It all depends on really the periodontal profile. If you have really weak periodontal, you have like a lot of bone loss, then splinting for periodontal reasons, but generally it's all individual restorations. Are you confident that the Theracem is completely polymerized through the opaqueness of the zirconia? Yes, I am, because it's a dual cure. So it's not just light cure. Light will just initiate it, and you still want to go, but I'll see, like when I hit my light, then I will see that the light is actually coming through, and I can see it through the facial when I'm on the lingual. So definitely the light is penetrating through the zirconia. But the thing is that, definitely a PFM, it's not going to, it's not going to penetrate. And so that's why I use Theracem even for PFMs. And so you don't have any light, I'm not using any light initiation for that because it's a dual cure. Okay. What material did you use to temporize the veneer case, and how do you cement those temps? That's kind of you're going to have to go to my pampacdental.com, because this is a real complex. I have basically 5 different ways in which I temporize, and it all depends on the situation. If a person flies in, or if a person is, so I have, from a real simple temporization all the way to a complex temporization. So I'm sorry, I can't answer that, but definitely, if you message me through pampacdental.com, maybe we can have a better dialogue about it, because it's definitely something that's not, I don't treat I treat temporization in a, like I said, I have many ways in which I temporize things. What cement works best for PFM? Definitely Theracem, because, again, the MDP. Inside the PFM crowns, I would micro etch it and put Z prime on it, because that is going to cause, the Z prime is not just for zirconia, but it's also for metal. And then that MDP is going to bond to the MDP with the MDP of the Z prime plus is going to bond to the Theracem. You're going to have a tremendous, we do that routinely, especially, for cases that I need to have metal still there. Okay. All right. I think that's it. That's all the questions I have. It's at 2:00 Hawaii time. You folks have a wonderful, wonderful holiday season. Enjoy. And if you come to Hawaii, then enjoy here. Okay. Well, thank you so much. Mahalo nui loa. Thank you. And I hope I was able to help you. All right. Thank you.